Hi, this is Dr. Randy Bach, and I'm thrilled and honored to have Dr. Ari Joffe with me today. Dr. Joffe, please tell us a little about yourself and what's been your mission.
Well, first, thank you so much for having me on the show. Uh, I am trained in pediatrics, pediatric infectious diseases, and pediatric critical care. So right now I practice pediatric critical care in Edmonton, Alberta, Canada. And but obviously have an interest in COVID because of my background training. And I initially was, for the first few months of the pandemic, was caught up in what I like to call the groupthink and thinking that this is a dangerous virus for everybody and we have to shut down. And the modeling from Imperial College and another model from, I think it was Kessler in Boston, that were scary. And then I started to read more, and three things influenced me to realize that I was really caught up in groupthink and not thinking for myself. And one of those was my sons, who are in engineering, who are started asking, are you sure that the lockdowns have more benefit than harm? And are you sure that just protecting the healthcare system is the goal of pandemic management? And then I heard a talk by Paul Fridgsters, who is an economist in London, England, where he talked a bit about what he called the Corona dilemma. And I heard a talk from John Ioannidis, who I'd read lots of his papers in the past, who is renowned epidemiologist, questioning some of the groupthink. And I started reading for myself and realized that the approach taken was, in my opinion, all wrong.
Yeah, I went down similar pathway. I have to say, I'm a primary care guy, but my reckoning, I think, was a little bit earlier because I was very attentive to the Diamond Princess as, an interesting fact of, an experiment, basically, that wasn't an experiment. You're on a cruise ship, you're not expecting to be a human experiment. But if we ever tried to reformulate or dedicate ourselves to making an experiment like the Diamond Princess, putting 3,500 people on a boat out at sea and then sprinkling coronavirus or Legionnaire's disease or malaria or something like that through the boat, no one would ever want to do it. But given that it had been done, and even Dr. Fauci mentioned it, I believe in February, as a something to observe, then nobody actually worked on the data that were there from that. So I always thought that this, saving the healthcare system or preserving it, whatever, was a little bit of an odd formulation because, in the United States, at least, pretty much hit Queens, the borough of New York City early on, which is, both the densest part of New York City, which is the densest city in the country, and the most polyglot. I think there are 400 different languages, argot, dialects, whatever, extant in Queens, and it's very fractured place socially, and a very dense place with elevators and buses and whatnot, subways. And so it was kind of an anomalous place. It wasn't Omaha, it wasn't Kalamazoo, and so forth. And so, early on, we made kind of a formulation to do these things when there wasn't that much going on. I mean, Bergamo, Italy, and northern Italy is also a very dense place, Milan and whatnot. And I think people, had kind of a category mistake or selection bias error of looking at odd places that were not similar to the rest of the world. And necessarily all other world density populations. But so what's the thing that kind of spurred you along, and where did you go with this?
Well, I wrote a few papers over the time, but the first paper showed me a few things. One is that the infection fatality rate from the virus is much lower than the case fatality rate. And the press was showing the case fatality rate, which is the fatality rate in people who have detected infections with symptoms. And the infection fatality rate was at least 5 to 10 times lower because most infections were not being detected. And so the infection fatality rate in people under 70 years old was less than 0.2%, which was far lower than what we were being led to believe. And then also realizing the extreme age dependence of the infection fatality rate, where older people, especially with multiple comorbidities, had 100 to 1,000 times higher infection fatality rate than young people. And so that was one point, that why are we shutting down everything when we know who the high-risk group is, the older people with multiple comorbidities, and we should be looking at ways for focus protection on those who are truly at high risk. And then I started, the other point that I learned was that there are many collateral effects of lockdowns, and that these were knowable and predictable and therefore preventable. And that was why previous pandemic plans that were published did not suggest anything that resembled lockdowns because of these collateral effects. And the collateral effects include economic damage, and loneliness and unemployment and education loss from school closures. And being a critical care doctor, I didn't realize that loneliness and unemployment were, and other social determinants of health were by far the most important determinants of population lifespan. And that by causing fear and loneliness and unemployment and all these collateral effects, that we were causing far more damage to population well-being than lockdowns could prevent, even if they were effective.
I completely agree with you there. You know, I've looked through the literature, and actually I've had Paul Freiters on my show 3 times, as we were talking about earlier, and he was on just last week. You know, I separately, he and I had both researched lockdowns as health measures, and they haven't existed. There are only 2 episodes, I think, in the 21st century. One was in Sierra Leone against Ebola, and it was not successful. And the other was at basically a kind of a prison TB ward, a closed TB ward for resistant cases, I think, with criminal histories, whatever. And they had a lockdown that facility in 2012 or something like that. And neither one were successful, but they're complete oddities in the history of public health. And lockdowns, you know, as a term they used in prison, and just to keep the prison analogy for a second, you know, the worst punishment you can get in prison is solitary confinement. You know, we go through a thing. The French have a word called anomie. And since you're in Canada, I'm sure you speak perfect French, or better than mine, which is namelessness. And you know, anomie is this situation where you lose sense of who you are. And you know, we need you know, and it's not just ants and bees who need society to define themselves and so forth. Humans do as well, maybe not as frequently, and perhaps not as pheromonically as the insects and whatnot. But we need each other. And as I think Barbara Streisand had it pretty well said, people who need people are the luckiest people on earth. And without that, you are, amongst the unluckiest people on earth when that need is kind of excised. You have a social ectomy. Your life is just kind of turned inside out. And along the lines of what you're talking about, these kind of QALY or Dr. Professor Freiders calls them wellbees. These units, I think, ultimately will show that the much greater damage over these last few years will have been from the cure than the disease. And the cure, bringing, one of my specialties has been narcotic de-addiction, and there was a huge upswing in narcotic deaths, not just because of fentanyl, potency, but because people just, had nothing to do, whatever. They start drinking more, drugging more, and whatnot. And I think there were something like 30,000 excess mortalities in the U.S. And I think 2020. Yearly and thereafter, and those are young people, a median age like 37 or something like that, and they're losing, say potentially 40 years of life. Wherein, most of I think the median age of death from coronavirus was 80 to 82, depending on which country you're in, and which probably for those people affected, nursing home quality, lifespan. Half of them were of that ilk. Nursing home, 45% were nursing home quality, either in nursing home or similar, and the median life expectancy for them is about 13 months, and at that age in general only a few years. So it's not like we want to sacrifice granny. I kept my own grandmother, we kept her here the last decade until she died from natural causes a few months ago, and all throughout the pandemic. So I'm not a granny killer, but I do think it's reasonable to stratify and to look at risks per age population. It's never been a one size fit all. Never lock everybody down. Never give everybody one treatment. Anyway, I apologize for that diatribe.
No, I agree with that. It's in fact, even the World Health Organization guideline for pandemic management that came out just a few months by chance before this SARS coronavirus 2 pandemic did not recommend the lockdown measures that were taken. And another thing that's important, many people accused me of saying, well, the economy is more important than lives, and that is a completely false dichotomy, because the economy is what determines population lifespan because of these social determinants of health. So if the government has to have austerity policies and spend less on social determinants of health, which are things like healthcare, education, roads, sanitation, social safety nets, and other things, then the population lifespan decreases. And so not looking at the economic effects was a huge mistake, because it also can be predicted to cause more harm to the population well-being and lifespan than lockdown. And yeah, Paul Fridgers showed me by listening to him and reading some of his things that the well-being, as you say, well-being years was a good metric, and it makes things commensurable or comparable. So, people saying, well, we can't compare the effect on economy versus lives, and that's just not true. We can use the well-being to determine the effect on population well-being and compare the different effects, both good and bad, and could have known that lockdowns would cause far more harm to population well-being than they could benefit. And having said that, then it turns out that more and more studies were accumulating that showed that lockdowns were not effective anyways. So they still caused all these collateral harms, and it's still considered controversial, but myself, I don't consider it controversial. I think the best studies and the meta-analysis I reviewed them with David Redman in one paper, and then Herbie and others have a meta-analysis that shows if you look at studies that are better studies because they use the difference in difference approach, that lockdowns had almost no effect on population well-being and mortality. And the mistake was that people looked at correlation that was not causation, as we should have known, because when the peak of cases was happening, and then the government responded with lockdowns, and the cases then came down, it was claimed, well, look, lockdowns work, but by comparing jurisdictions that did different things, that's not the case. It was just the natural course of each wave, and it was not due to lockdowns. So
yeah, no, that's actually, I think that's accurate. The United States, we forget it's a collection of states, and the states have their individual rules. I mean, you in Canada don't forget it because you have provincial governments, but perhaps in Belgium they might, kind of being under more federal sway. So the one of my favorite examples is North versus South Dakota. At a certain juncture, I think it was 2020. North Dakota went one way, South Dakota went the other. It doesn't matter which. They're about identical populations, identical ethnicities, identical politics. They both have, they're both red states and so forth. And I think one of them was continue to lock down, the other one didn't, and they had pretty much the identical, residuum. I think the one that didn't do the lockdown did a little bit better. This is not the first phase, but like the second phase or whatever. And you can do all these kind of state by state comparisons. In the U.S., Florida has I think a slightly greater population than New York State, but comparable. And Florida skews elderly because it's what do they call it? Heaven's waiting room, and Florida had a lower case fatality rate than New York State did, pretty much throughout all the more severe phases of the first year and a half. So, there are ways of looking at these things, and nobody ever, within the establishment ever did. And, I think there are sins of commission and there are sins of omission, a little bit like what the newspapers do. Oftentimes it's not the stories they tell, it's the stories they won't cover. And this seemed to be one, if it reflected poorly on the establishment, they didn't. It used to, back in the day, I think, our cohort, was question authority, don't trust the man, don't trust anyone over 35. But now, kind of that rebel sentiment has congealed a little bit, and everyone's, wanting the authorities to be authoritarian. Anyway, so I would like to, put the ball back in your court a little bit. Maybe, we can look at some of the articles, I think, a little bit later on in the discussion. I'd like to, go over them a little bit, but in the context of who you are, where you were, Canada, and how things have been, how was your work received, and how did it act for you or against you on a personal or professional basis?
Yeah, that's a good question. I have to say I'm probably a bit of an exception because I'm not on social media. So I did not see Twitter or Facebook or other things. I heard from some people that I was being criticized, but I didn't bite and engage in that. I gave a presentation early on, September 2020, to our ethics center and to our critical care grand rounds, and it was received well, but no action was taken on it in terms of not advocating for lockdowns or school closures, etc. And I did write an editorial piece in the paper, our local journal paper, and I was surprised that a group called a local group of physicians, the I forget what it's called, but a physicians society wrote a reply that was basically all straw man arguments, misframing what David Redman and I were saying, and basically trying to ridicule what we were advocating for. And then, to my surprise, I also, because I'm a member of that medical staff society, I saw an email sent out to all the physicians in the medical staff society where they said something to the effect that they were pleased that they were able to take down what Dr. Ari Joffe said. so, but again, I didn't engage with that. Basically, it was being labeled misinformation, which, as you know, in this pandemic, anything contrary to the one narrative is being labeled misinformation and not allowed to have any hearing. So I decided, instead of doing presentation and speaking out, I would just write some papers with my point of view and hope enough people saw them. So it did not affect my career or practice. I may be a bit protected because I'm in pediatrics, where there was a bit less panic than in adults.
Yeah. So I've got a couple questions. One of my good friends is a pediatrician, and he's fairly prominent locally, and reasonably early on, a couple months into the coronavirus experience in the U.S., probably by May or so, he had come down with coronavirus, ancestral version, and very few symptoms. He's a healthy guy. We play sports together. And his wife had it too, same thing, a little bit of cough, maybe, kind of mild flu symptoms, whatever, maybe flu symptoms themselves. But thereafter, I asked him, I said, wow, I'm so happy you're well. And, thank you for being our local neighborhood guinea pig. So this kind of means you don't have to wear a mask anymore. He's like, no, I'm going to keep wearing a mask. I'm like, why is that? And this is before it all had consolidated. And he said, well, it's not really the right time yet. I mean, what do you mean? I said, do you think you're going to get it again? He says, no. Do you think you have full immunity? Yes. Et cetera, et cetera. Do you think you can give it to, do you think you can get it again and give it to somebody? Do you think you can catch it from somebody? No, and no. So fine. He thought he was pretty much done with it. So why are you still wearing it? He said, well, it's kind of, long story short, basically it wasn't politically the right time yet. There was still a push to get rid of President Trump, and, they wanted to keep the pressure on him. And so I listened, I said, oh, wow. And walked away. But, it just seems kind of like there were some extra medical, extracurricular aspects to these decisions. So first of all, in Massachusetts still today, and even in outpatient settings, if a healthy, 28-year-old physician seeing a 13-year-old kid with an elbow fracture, everyone's got to be masked. Is that going on still in hospitals? Is that going to go on forever? What were your experience with masking, and has that, given the recent Cochrane report, again, which I sort of, prejudged, I guess, as likely to occur. What's been the situation with, let's just stick the masks and the kind of ethos around those?
Well, in our province, masks were mandated in society. So that was for many months. And in our hospitals, masks are still mandated, continuous masking. And at first I thought that was less of a priority to speak out about than lockdowns. because I think lockdowns did far more damage. But reading more and thinking about it more, I think masking was a big problem for several reasons. So, one, the best studies, which are, as you know, randomized controlled trials, before the pandemic, showed that masking was very unlikely to have any effect on spread of respiratory viruses. And then there were a couple of good randomized controlled trials during the pandemic that showed again masks in the community did not affect SARS coronavirus 2 transmission and cases. And then, as you mentioned, there was the updated Cochrane review, which again showed that using the best evidence available that masks are not effective in the community to prevent spread of respiratory viruses, including SARS coronavirus 2. So I think that one, we knew that community masking was very unlikely to be effective. And if it was mandated, in my view, there should have been cluster randomized trials in the community to see if it had any effect, because the only evidence we had before was that it would not be effective. But it has adverse effects that were downplayed. And one of those is that it's a constant reminder to be afraid of everyone in society as a vector of disease. And you wear your mask, you're afraid of being around people. And it was a visual reminder that you have to be locked down and have to be afraid, in my view, unreasonably of the virus. And then as a pediatrician, it was particularly harmful, I think, to young children, because not only did it teach them to be afraid of their possible friends as vectors of disease, and to be afraid that they might kill their elderly grandparents, but it impeded language development, it impeded facial recognition and recognition of emotions and intentions of others, and facial recognition. And the question I have is how reversible those things are, which we simply don't know.
Yeah, no, we might these days people seem to get their dogs from the shelter. I'm not sure about where you are. There used to be more dog breeders, and then dog breeders kind of became persona non grata. I assume these dogs come from someplace, so they're getting bred somewhere, but everyone goes to the shelter and they get these dogs who've been abused. I'm not sure who abuses dogs. I'm not sure how they wind up in the shelter, etc. But there are the dogs I see, the puppies are different from the ones that are, taken from birth and you get to bring up, because they have some, emotional damage. I mean, PTSD in dogs. I mean, I don't know if the D stands for dog or disorder, but or disease. But there used to be this common plaint. What about the children? If you wanted to do anything, people would, say, what about the children? And get caricatured in The Simpsons and whatnot. As somebody who wants to stop anything, you want to put a trolley, downtown or whatever, and be like, what about the children? And it's kind of a NIMBY thing, not in my backyard kind of thing. But in reality, though, we should be thinking, what about the children? I think we've lost track of that. And even the people who are directly caring for it. I mean, I have done some urgent care in the last year, on a temporary basis, and my time in those offices were masked, and you just have a hard time establishing a relationship. And in urgent care, you're seeing people for the first time, or seeing part of them for the first time, and they're seeing part of you for the first time. And I mean, we could easily do this Zoom call with half, I'm going to take my mouse pad, we could do the Zoom call like this for the duration, and people would hear us, But I think they lose a lot of visual cues. I mean, I think that's why people, we get a lot from looking at faces. We have a full face. Not every animal, has the kind of facial expressions we have. I don't know how many, 37 different facial muscles, whatever the number is, maybe more. We have huge nuance in the things we can do. We can tell fake smiles from real smiles and whatnot. And we judge these things. And I think it's a very precarious position. I'm just going to bring one sidelight. A friend of mine, a physician friend, sent me today an article by David Zweig, who has gotten pretty big during the Twitter files, and he's a journalist, not mostly national security, but trusted journalist. And he has an article today in Barry Weiss's blog, which I can't remember the name of it. I think, but basically, there's a school in Ithaca, New York, home of Cornell and Ithaca College, that today still has full masking. They have silent lunch. They have social separation, and it's a Montessori school, and the parents, I presume they're professors, sending the kids to Montessori, not so much the locals and the plumbers and the firemen, but probably the professors, and they spend what's for here a good rate, but $15,000 or whatever to send their kids there, and they're sitting there in this social enemy, this nameless facelessness. I don't know. I sent my first kid to Montessori, and it was an interesting experience, but it was social. They have open classroom, the kids are different ages, and there's a lot of play and whatnot, and he liked it. But what they're selling as a strong point of Montessori is not their math. It's not like the Russian school for math, whatever. Not selling their academic skills. They're selling, selling this social aspect, and this seems totally inimical to the experiment. And we, again, are social beings. Anyway, so where's the question there? I don't know. Where I guess the question would be, where does it all end? Who says what? Are we going to be masking in hospitals forever? How about that question?
Yeah, I just want to comment a bit first before I get to that about what you said about the schools. I think my colleagues often said to me, well, we have to protect the children. And I would say, from what? Like, look at their infection fatality rate and hospitalization rate. It's far lower than influenza every year. What are we trying to protect them from? And I think a mistake was made because people thought they have to protect their children from SARS coronavirus 2. And I think that was wrong. We have to, what I think is we have to protect our children, period. And so we didn't protect them. We caused them harm throughout this pandemic. And that's by closing schools and by forcing them to be masked and by inducing fear. And so much learning loss, and the best studies about masks in schools show that the masking had no effect on cases in schools, teachers, or the community. So that was a big mistake. Now, in terms of hospitals, masks are useful for individual encounters. So if someone has an infectious respiratory virus, the infection control is to wear a mask when you're interacting with them. But this continuous masking, I think the best evidence we have is against. And I think, again, it perpetuated fear among hospital staff and was harmful to children in hospital and families in hospital without adequate study and with no evidence of benefit. So when is it going to end? I don't know. I hope soon. I sent an email to locally to our hospital administrator asking that very question a couple of weeks ago, with quoting several studies and saying that I think it's time to stop. And in fact, in British Columbia, I think just this week, so that's our neighboring province, they ended continuous masking in hospitals. Yeah. And I think a sign that the pandemic is over and that we're in an endemic phase is let's get rid of hospital masking. One thing that is interesting, many things are interesting, but one thing that's interesting is we had these hospital screeners who would hand out masks to people and enforce, that if they're had any recent contact, they can't even come in to visit their sick loved one or relative or best friend and these people were there continuously at every entrance to the hospital, screening and handing out masks. And I always thought, what a waste of human resources when we are short of staff on the wards. And and they're still there with masks, although they don't screen people coming in. So
I kind of might want to make a segue here.
I don't remember.
I made some slides from some of your articles, and maybe we could just kind of spend maybe 5 minutes. Maybe you kind of annotate some of these for us. Would you mind that?
Sure.
Okay. Also, there seems to be a tapping noise. I don't know on your end. I don't know if you hear that, but at any rate, so you can speak to these. This is, I think, one from your 2021 article. I think this comes from Professor Freiters as well. Do you want to just kind of maybe give a sentence or two on each of these?
Sure. This was to show that even a temporary decrease in GDP causes a large long-term loss of spending by governments, because as you see on the where there's an 8 trillion, there's an initial downswing, and then it takes many months and years to catch up to what the growth would have been. So even though the economy is starting, to recover, it's not reaching what would have been the counterfactual for several years, and that's
this plays out. This plays out in poorer countries even more, because they're kind of the ones trying to pull up a little bit from bootstraps and whatnot.
Yes.
This is from a more recent article, I think, with Dr. Unitas and Professor Shippers.
Yeah. Yes, this is a figure that Dr. Shippers worked on. And basically, one thing on this to emphasize is mass formation. And that's something that is a whole topic on its own. And there's a book by Matthias Desmet about that. But the hardship and crowd effects and psychological tactics all led to mass formation, and people's experience of social isolation and meaningfulness and anxiety were co-opted in fighting this military analogy of fighting the virus. And I called that groupthink, and it's more accurately called mass formation, leading to crowd behavior, where everyone was calling for all these mandates without realizing or cluing into
just
their
doing it for today, doing what they need to do. These are a couple tables. These are pretty dense for our viewers. So maybe just give a word or two on what these are about.
Okay. Yeah, this is very important. So people ask, well, what then should we have done? It's easy to criticize what was done, but what should we have done? No one knew what to do, and there was lack of information. And those are not the case. There were previous pandemic plans, and there was much information at the start of right from the start of the pandemic that could have led to far better responses. And responses were led by physicians, mostly public health and medical so-called experts. And these, including myself, have had no expertise in emergency management. And I think that was the biggest mistake in the pandemic, because there are what are called emergency management agencies that follow the emergency management process. And if I can just talk a bit about the emergency management process, I'll point out a few things where we could have done better. So the first step in the emergency management process is identifying the hazard. Here it was SARS coronavirus 2. But then it's selection and maintenance of the aim, which is the main mission of response. And the aim is to minimize the impact of the pandemic and its response on the society. It is not to flatten the curve or protect the medical system. Those may be sub-objectives, but the aim is to minimize the impact on all of society. And so the wrong aim was chosen. And then the next step is to establish a governance task force. And that needs a leadership for all policy programs and actions taken. And it needs a very diverse stakeholder involvement, and should be led by the senior government official, not by the medical officer of health. And but so the medical officers of health and medical advisors were given undue influence in making the eventual decisions.
Right.
But in terms of how to make the decisions, there are three important steps. First is risk hazard assessment. So, and we knew that. We knew that the risk of the virus very early on, we knew it was extremely age dependent in older adults with comorbidities. And we knew it would have impact on critical infrastructure, one of which was including healthcare. And so based on that, the Emergency Management Agency would have known to do a mission analysis, and that's to determine what the objectives are. And then that's followed by defining different courses open, and to determine how to achieve the mission. So the mission is what needs to be achieved, and the next step is determining how to achieve that. And the important point in how is to do cost-benefit analyses and consider all the potential collateral damage and all the ways of focus protection. One of the tenets of emergency management is to remove those at highest risk from the hazard. And so this table shows the four priorities of an emergency management response. And one is preparation, and that is having the pandemic plans, which we had, and knowing what the government's task force would involve. And then the next priority is mitigation, which should be focus protection of the most vulnerable. So the focus should have been on a plan for long-term care homes and protecting older people living in the community with multiple comorbidities. And the response should have ensured there was critical infrastructure ready for people who got sick, and to ensure that the rest of society can continue its functions. And one of the main goals should have been to increase healthcare capacity. And I think that that goal was not met in most jurisdictions, at least locally. Instead of increasing healthcare capacity, the existing healthcare capacity was just reallocated by closing down care for everything except COVID. And that is not what surge capacity is about. Surge capacity means creating more capacity so that you can continue healthcare as usual for all conditions, and also manage the surge of patients expected in a pandemic.
Mhm. Those are excellent points. I'm just going to zip through a couple slides because our time's getting short now,
Yeah.
and I'm gonna maybe I'll just kind of voice over some of these for people. But these are from your 2021 article where I think you're rebutting some of the points made. So you're talking about how it started with kind of modeling, which was not really good modeling, how it took off, crowd effects, and I think there's a little bit about the mass formation, not mask, but mass.
Yeah.
People objected whether this was age discrimination to, do focused protection. But the fact of the matter is, like you say, and I actually did a spreadsheet on this. The people who were in the nursing home versus, your healthy 7-year-old, there was almost 10,000 times greater risk, which is not shocking at all. I mean, I think that's probably true of anything. Even we're like walking around the corner or getting on a skateboard, it's probably 10,000 times riskier for an 85-year-old in a nursing home than it is for a 7-year-old. People talked about the herd immunity threshold. So I'm going to show people your articles when we link to this. But these are topics that people brought up as, I think, a little bit red herrings. Sweden, people, it was a very polarizing topic. I think Sweden ultimately has done very, very well, and they did it at very little societal expense. They did not shut down. They did not close the schools. Kids went to school, aside from, I think, a few-week period early on in the spring 2020. They stayed in schools for the duration. The teachers didn't drop like flies. The kids didn't drop like flies. They didn't infect their grandparents and so forth. I think Sweden had a structural issue early on insofar as they had these group nursing homes. And so there was a high kind of like what I call the Andrew Cuomo effect early on, before Andrew Cuomo had the brilliant idea of sending people in convalescence from SARS-CoV-2 back to nursing homes rather than to some wayward place like the USS Comfort, which Donald Trump had put into New York Harbor. So people had like these kind of political layerings, and they brought up Sweden as a problem because, again, they had a high early phase of fatalities, but then they evened out and they've done better than most of their congeners in Northern Europe, et cetera. And so, again, I'm just going to a little bit gloss over these because time is short. What you talk about, iatrogenic means doctor caused. Collateral harms, lockdowns as a drug with dangerous side effects. If lockdowns were a drug, it would be probably on a par with fentanyl. People care about that. They care about the opium epidemic, but doctors and the big doctors and group doctors and kind of the doctor thought was polluted in a sense, and people did not have a firm grasp of numbers and reality. And you bring this up, numbers and context, and then this is Professor Freiter's Wellbeing and QALY, quality adjusted life years. I'm not going to be able to spend a lot of time on this, but again, the calculation is enormous in the side that the cure of lockdowns, et cetera, was far worse than the illness. This is a slide from one of your pieces showing kind of relative risk. People do die, and there are other things from which people die. Dr. David Bell has been on my show, and he's pointing out that the money taken away from malaria, tuberculosis, HIV in Africa will cause far more deaths because the money's been diverted to COVID-19 vaccinations and treatment, all this kind of stuff, and masking and whatnot. And the numbers will far exceed any lives saved regarding COVID-19 in the duration. But I wanted to get to this slide here. So that was my quick breeze through some of your work. I apologize for being your mouthpiece. But maybe you could talk about this. I kind of find this an interesting slide. We can talk about this trolley effect for maybe 3 or 4 minutes and try to come up with some concluding thoughts.
Sure. So the classic trolley dilemma is whether to pull the lever. You see the trolley heading toward heading toward many people, and you decide whether to pull the lever and make it hit the one so that you save the many. And the way the corona dilemma is we see the trolley going for one group of people, and we decide whether to divert the trolley and save that group. And when we did that, we neglected to consider that there were so many other people on that diverted train track. Because the diverted train, as it says here, will put whole countries into isolation, destroying many international industries, and thus affecting the livelihood of billions, which through reduced government services and general prosperity will cost tens of millions of lives. So if we had not diverted the train, you let the virus rage unchecked and cause COVID deaths. But when we pulled the lever, we caused far more population well-being loss. And that is even a bit misleading because the plan was not to let the virus rage and be unchecked. We would have focused protection on those that were on the non-diverted trolley track to attempt to protect them.
Yeah, that's an excellent point. So I'm going to pull this down for a little bit, and I guess I'm going to again do some from your work. I'm just going to breeze through a couple of these, and then we'll come up with concluding statements. These are from your pieces. These are mistaken assumptions. No one is protected until everyone is protected. You can maybe talk about these in conclusion. I'll just kind of, people want to look at these, they can pause the video and just read them. Mistaken assumption: lockdowns are highly effective to reduce transmission. Mistaken assumption: lockdowns have a favorable cost-benefit balance. Lockdowns are the only effective option, and I'm going to leave it with that. This one, I guess, is a little bit empty. So in maybe 3 or 4 minutes, might you want to discuss any of those assumptions and what we can take away from this, what I think is kind of a overbearing, horrible experiment, worst year ever, and I want my money back from 2020 on. So what are your thoughts there?
Well, it's hard to put it quickly, but in that paper, we were arguing that lockdowns, implementing lockdowns was based on flawed assumptions. And the main assumptions were that lockdowns work, and I think the studies have borne out that they did not reduce transmission and the effect on the community rates of COVID. And the other assumption was that if they work, they have a favorable cost-benefit balance. But even if they worked, they did not have a favorable cost-benefit balance because, as we've talked about, they had so many collateral effects that in the end, they will have caused more loss of population well-being and lifespan than they could have prevented from COVID. And again, we went over that people think, well, that was the only thing we could do, and that's not the case. The emergency management process could have come up with far better plans for focused protection of those who were at risk, that is, older people, especially with multiple comorbidities. So, yeah, in my view, I think the response was led by mass formation and groupthink, and in my opinion, the people in charge were not the correct ones. I think we had emergency management agencies who have experience in this, and we had previous pandemic plans, and we erred in not using both resources.
Fair enough. Well, thank you. I'm going to end with my own shameless self-promotion. I have a book out. If you'd like to help support my efforts in doing this podcast, I try to bring what I consider the profiles in courage of the COVID sensibility, COVID resistance. or lockdown resistance for freedom to the public. I have a book out called Overturning Zika, which does that, I believe. It's the pandemic that never was. I have an article in the American Journal of Medicine if you want a shorter version, and one in Brownstone as well. You can buy this. I appreciate if you leave a review. I'm not going to be able to sign it, but you'll have my portrait. This is me in the morning. It's being published in Brazil in the next couple of days, I think, by a major publisher there. So we're going to see how things go. My angle is, I'm not an infectious disease person. I'm a primary care doctor. And I thought there were a lot of anomalies with the Zika microcephaly phenomenon when it came out in 2016. I didn't really write on it, but I thought I had never heard of Zika. All through medical school, never heard a single mention, and that's because it's not a human illness. But it turns out there are 4 strains of dengue, and if you want to see this prop here, Zika would be like the 5th of these dengue 1, 2, 3, 4, and Zika is really dengue 5. But dengue, millions of cases over the decades never caused any increase in microcephaly. So that's what I was looking at in 2016 when it came out. And I hadn't, I found out Zika was pretty much dengue. Dengue never caused this, and I was like, well, this is gonna turn into a nothing burger over time. And I forgot about it because I had other things to do. And then Facebook kind of jogged my memory with one of their memory jogs. And I was like, oh, 3 years have passed. What did happen? I started looking around, and it had not recurred. So I was right. That's one of my top feelings in life. And so I wrote a short article. I tried to get it published in New England Journal and this and that everywhere, as well as Wall Street Journal, whatever, any journal. And I couldn't get it published. I had a Zoom call with the editors of JAMA, Doctors Livingston and Bauschner, in early 2020, and they were interested. They said, well, we'd like to publish this because your arguments are interesting, and nobody's brought this up, that maybe there was no there. Maybe it was just a conjecture, and that Zika doesn't actually cause. They kind of, steamrolled and panicked and whatnot. It turned into that. And he said, but there's this coronavirus thing coming around, and we don't want to sow any doubt in the public health establishment at this time. Anyway, so they didn't. And so I thought to myself, I have to write a book on this to kind of get around the roadblocks of politics interfering with what I think should be medicine and actual care. And there are, billions of people in the tropics who live under this, false fear of a single mosquito bites unalterably changing the cherished life within if you're 0 to 3 months pregnant. And so people slather on insect repellent, they stay indoors, and if they do have a microcephalic baby, they feel tremendously guilty when in fact most of the causes of microcephaly are diffuse and unknown and do not include Zika. Anyway, so that's been my journey, and I've been trying to get the word out on that. So if anybody listening to this has any advice on how to promote this, let me know. Anyway, so last words for you, Dr. Joffe.
Well, thank you so much for having me on, and I hope people read more details in the papers that I've written.
Well, I agree, and I'll try to put up links when we post this. So thank you so much. You can stay on, we'll chat, but I'm going to say goodbye to everybody else. Thank you for joining us, and stay tuned.